Hey team, welcome back to another episode of the Student Paramedic podcast. Hey team, welcome back to another episode of the Student Paramedic podcast. Today I'm sitting down with Matt Shepherd and also Britt Shaw. Most of you will know Britt Shaw from our first ever episode, and we're also talking to Matt. So Matt is a MICA flight paramedic. I'll get Britt to introduce herself and Matt as well.
Hey guys, so if you haven't heard the first episode, I'm Britt. I'm a graduate paramedic with New South Wales Ambulance based out of the North Coast area. I'm coming up to my qualifications, so only a few months left around the North Coast before I head off to somewhere else in New South Wales. This is my second episode now with the Student Paramedic podcast team, so I'm really happy to be part of it. And Matt, popping on in from Melbourne, would you like to tell our listeners a bit about yourself?
G'day, my name is Matt Shepherd, and thank you for inviting me to come along and have a chat today. I'm a paramedic of 22 years now and have been a MICA paramedic since 2003 down in Victoria and a MICA flight paramedic since 2009. So appreciate the opportunity to come and have a chat and talk about my experiences.
Awesome. Well, thank you. We can't wait. Today we're doing a bit of a different episode and Britt can introduce it a bit more. It is CPR Induced consciousness. This is something that I've just come across and we're going to talk a bit more about it because it's quite interesting. So, Britt.
Yeah, so the original idea from this, when I first met Matt, actually, it was down at a conference in Brisbane where he presented on this topic. And I think it was the second time I'd ever presented and I was directly following Matt on a similar topic. So that was only moderately mortifying for myself. But CPR-induced consciousness, it wasn't something that's sort of been spoken about much until now. Matt, can you tell us a little bit about what it actually is?
Yeah, certainly. So this all came about essentially from going to a conference and getting on a beers with one of my friends who was a paramedic, has now become a doctor, and he was interested in research. And we started talking about a couple of the jobs that I'd been to, and I mentioned that I'd been to a cardiac arrest where, while performing cardiac compressions, the patient started to wake up. And he didn't believe me. He said, you're rubbish, you're lying, you're full of crap. There's no way that anything like that could happen. But I explained the story that, we would do compressions on the patient. It would obviously increase the perfusion to their brain, so much so that it would allow their body to start doing functions that they normally wouldn't do during cardiac arrest. And he finally came around to the idea and said, that's really interesting. He goes, we should do some research on it, see if there's any more information on it, and we can sort of gauge whether there's a guideline that can be applied to it or anything like that. And so I said, yeah, sure. And I finished my beer and we carried on for the rest of the night. Let alone I know the next morning he comes to me with this proposal that he's quickly written up on his computer when he got home that night. I went straight to sleep. He obviously went straight to his computer and wrote things up. And he suggested we should do a research paper on it. And so it sort of stemmed from there that we'd actually get involved with research and actually write some articles on it. But essentially it is. So during a cardiac arrest, obviously we have a decrease in the amount of blood that's circulating around the body. Obviously we perform cardiac compressions and the expired air resuscitation to try and improve oxygenation and perfusion throughout the body. There are times when we do that compressions and the ventilation, and it provides such an improvement in the patient's oxygenation and perfusion that it actually causes their brain to operate as it normally would. And not to the degree that they get up and have a conversation with you, but there's certainly been reports of people communicating quite clearly with the resuscitators at the time during the cardiac arrest. So we're actually having compressions pushed on their chest up and down, and they can be asked a question at times and respond to that question. Now, that's not everybody, and it's only a small percentage of people that actually find themselves in this situation. However, there's many things going on nowadays which improves the prevalence of this sort of situation occurring. And probably one of the big ones is the Good Responder app, the Good Sam app. So people in the local community are responding to patients in cardiac arrest a lot sooner and starting compressions and so forth much earlier than what they did before. So the shorter the downtime, the greater the incidence is that you will start to get a patient with CPR-induced consciousness. because perhaps their oxygen levels haven't been completely depleted out of their body. The brain still has a level of oxygen in it, and you start compressions and expired air resuscitation early, and it brings up that level of consciousness during the cardiac arrest. Does that make sense?
Yeah, it does. So for the students who are only just starting to understand sort of the ins and outs that come with cardiac arrest, this is a very different topic to what we'd see with a patient who's experiencing ROSC, or return of spontaneous circulation. These are patients who are still in an arrest, who still do need that intervention, but they've just got some form of brain function effectively.
That's right. And so routinely with a patient in cardiac arrest, you will do the cardiac compressions. You will see no signs of movement, no signs of activity from the patient at all. When you get a patient that's got CPR-induced consciousness, they can affect your performance with your cardiac arrest management. And we talk about CPR interfering and CPR non-interfering. And so a non-interfering case is you're doing compressions and the patient may be opening up their eyes and looking around, and it appears as though they've got an awareness to what's going on in their external environment. And that's not too much of an issue because we can still perform our cardiac compressions as normally would. However, if you have a patient that's got CPR interfering with the cardiac compressions, you'll find yourself in a position where you're doing compressions onto the patient's chest, and that patient may be grunting or groaning or localizing that painful stimulus. We hear reports of patients actually localizing the paramedic's hands and trying to pull the hands off their chest and stop them from doing compressions at that time. We've also got case reports of people clawing themselves along the floor trying to get away from a paramedic doing compressions. Initially, when we talked about this, there was a lot of kickback from the hospital saying that this is rubbish. You know, the patient's obviously not in cardiac arrest. You're doing something on, performing cardiac compressions on a patient that doesn't really need it. But quite clearly, when you look at the monitor and the printout from the monitors, it clearly indicates the patient may be in VF or VT or even a PEA, whatever it is, but has inadequate perfusion. So if you stop doing the compressions, that patient becomes unresponsive again and pulseless. So you don't actually feel anything or see any activity from them at all. So it's only associated with doing good quality cardiac compressions. Obviously, there is a factor of the time frame from collapse to compression starting, which can have an impact on whether you'll actually see this occurring as well. But it is rare. I must point out, it's not something you're going to see every time. It's about 1 in every 100 cases that you'll come across that potentially you may see it.
Yeah, so I was just telling Alex earlier, the second ever cardiac arrest I was involved in, we actually ended up with CPR-induced consciousness. So it was a gentleman who, it was a witnessed arrest. Second time I've ever done CPR. It's a daunting moment when you've got a patient, and for this one it was CPR interfering. So he was reaching out, grabbing at my thighs, grabbing at my arms. I was a second year student. I barely knew even how to do the arrest, let alone what to do when this is happening. And this was back before we even had a lot of conversations about it. So for yourself, sort of, typically I'm guessing you'll mostly be the team leader at these events as the MICA paramedic walking in. If you do witness it, what sort of changes with the arrest? Is there anything that you're looking at in forms of sedation or in forms of talking with the team on scene?
Yeah, so it's interesting. So initially when we started, as I spoke to that, my friend, which is Alexander Olausen, he didn't believe that this sort of stuff occurred. And we got the same sort of feeling from a lot of the hospitals that this was something unheard of. So initially when we started doing the research on this, there was a lot of disbelief about this actual presentation occurring. So therefore, really, in reality, there really weren't many guidelines or any recommendations as to how you should manage this patient. So what we did was decided to go out and work out what the incidence of CPR-induced consciousness actually is. And then if you are presented with it, how would you actually manage it? So we have lots of medicines that we carry around now as paramedics in our pre-hospital bags. Obviously, we've got things like morphine and fentanyl. Now more days we've got ketamine and methoxyfluorine and lots of other drugs which can be administered to try and sedate or control the movements of any patients that you have. We did surveys with doctors and nurses and paramedics about what they thought was the ideal agent to use in a patient with CPR-induced consciousness. There were some people that said, well, just give them paralysis, because they didn't believe that the patient would have any memory or recollection of the events that are occurring during the cardiac arrest. So you can just take away their muscle activity and just go ahead and perform cardiac compressions on them and stop them moving by giving them a paralysing agent. And quite clearly that didn't sit well with me at all, because I didn't like the idea of somebody being paralysed during a cardiac arrest and having the potential to have some recollection of the incident, because it would be a very traumatic experience being paralysed on the ground and having someone thump up and down on your chest. And it's been proven in a lot of research that some people do have, near-death experiences where they can recall events that have occurred during a cardiac arrest. So I think providing sedation is really important. So let's take the paralysis out of it. We're not going to be using any of those. We need to think about what forms of sedation would be appropriate. So I guess one of the things you need to think about is, well, how does sedation affect our cardiovascular status? And some of the medications, more things like morphine, they have a tendency to cause hypotension or cause some vasodilation. So we consider that to be a detrimental medication to be using during a cardiac arrest, because we want to try and limit the effects of any medications we give that are counterintuitive to what we're actually doing. So fentanyl has less cardiovascular effects. So that was one of the medications that we decided we would use during the cardiac arrest. And initially that was given for the ALS paramedics to use, because initially when we introduced the guideline, ketamine was not available on ALS vehicles. Obviously things have changed now. We've moved on a few years and ALS crews do now carry ketamine. So the ALS would give fentanyl and MICA crews would give ketamine as the other medication. Ketamine's been shown that it has less cardiovascular effects, it maintains respiratory function and also maintains airway control as well. So if the patient has got that, we do get ROSC, that hopefully those breathing efforts and airway control will continue to be there when they do develop return of spontaneous circulation. So that's what we broke it down to. We looked at international guidelines. We found the Netherlands had a guideline which used fentanyl, and I think from memory, Canada was the other guideline that we looked at, which also used fentanyl. So we ended up with fentanyl and ketamine. The plan is for the future that we're going to review the cardiac arrests that have occurred in Ambulance Victoria since that time and see how the guideline is actually going. Anecdotally speaking with several paramedics, it sounds like the doses that we recommended were not going to be enough. We initially recommended 20 milligrams of ketamine IV for the intensive care paramedics to administer. And we're hearing that multiple doses of ketamine are required to actually sedate some of these patients. And also the fentanyl dose of 25 to 50 mics IV is also not appearing to be enough as well. So we may need to just go for a blanket dose like what we do with an RSI or something like that, and maybe give 1.5 milligrams per kilo of ketamine and maybe 100 mics or 50 mics of fentanyl, depending on the size of the patient. So it's all unknowns, really, and the guideline was just generated with what we deemed to be appropriate. And obviously we did this in consultation with physicians from the Alfred and Monash and Royal Melbourne Hospital to try and work out an appropriate dose. And so you've got to start somewhere, and that's where we started. And I think we're going to need to change it and improve it from there.
Okay. And so when you're administering these medications to sort of manage the CPRIC, you then have a patient that you have, you obtain ROSC on. Does that sort of change your management from then onwards if it's someone who you're looking at potentially RSIing? Do you have to sort of factor that in when you're reassessing them? Is there sort of any changes to that pathway that's had to be implemented?
And not necessarily so. So when you get ROSC on the patient, it's back to square one. So you reassess them from the start again, and it's airway, breathing, circulation. And you do that every time you get a return of spontaneous circulation with any patient. Whether they've received sedation during the cardiac arrest may affect how they wake up after the ROSC. But also the big factor in that is how long they've been down for. You know, if you've been down for 2 minutes, the chances are that you're going to wake back up to a GCS of 15 straight away. And more than likely, we won't have got any medication into you anyway. But if you've been going for a long period of time, the chances of spontaneously waking back up to a GCS of 15 are going to be very low. So more often than not, with those types of patients, definitive airway management is required, and that will be the form of intubation pre-hospitally by the form of an RSI. So it all depends on each patient. Obviously, there's no black and whites in this world, as we know, but just reevaluate, go back to your ABCs, start again, do an assessment, and then consider, because, in reality, when you go, right, well, we need to intubate this person, you've got a 10-minute window there. Perform assessment when you've got ROSC. At the 10-minute window, perform another assessment, see where you're at. If the patient's still obtunded enough, then perform your RSI. If they're waking up and continue to be going on an upward trajectory, then allow them the opportunity to wake up and not perform the intubation.
Absolutely. That makes a lot of sense. And as a student who has, one, never come across this in my placements, and two, only recently heard about it. I think I only ever first saw it on one of the TV shows. Now, this is something that is a bit out there and we don't see it very often, but how do you tailor the debrief process? Because usually you'd go to a cardiac arrest and you'd have a debrief process afterwards and it's quite straightforward, whereas this is something pretty much your whole crew might not have ever seen. How do you tailor that process?
I think the biggest thing for anybody experiencing CPRIC for the first time is the uncomfortable situation that you experience, in that you're providing cardiac compressions on somebody which appears to be causing pain and discomfort to them. We all know that it's a necessary form of management during cardiac arrest, but when you actually do it and you can see the discomfort that it's causing, or the agitation or irritability through the pain that's associated with it, it becomes very unsettling for you, especially if you have a patient that is, some of them can sometimes verbalize things and nod their head or, blink their eyes to your questions and so forth. So, that sort of situation, knowing that if you stop, that person dies, is very unsettling. So any debrief that you have, obviously in a situation like this, you need to look out for each other. And I think we do that very well as paramedics, that you send each other a phone call or have a chat, but certainly after the job, if the service allows you, take 5 minutes to sit down and actually get the opportunity to say things and get things off your chest. And as we know, services are very busy at the moment, so that opportunity doesn't always arise. But we do have a lot of counselling services within ambulance services throughout the world now. And, if they don't catch up with you straight away, they usually will get around to you within a period of time afterwards to see how you're going.
So I guess this is obviously something, because clinicians, like we've said, it's something that we'll rarely see. If you do see, it's that 1 in 100 opportunity. It can be a bit distressing and sort of confronting to us as the clinicians on the scene. The bystanders and the family of these patients, it's something that, it's sort of, from the ones that I've seen and some of the videos that you see, it can be something that is quite horrifying and horrific if they're not having that understanding. Do you yourself have a script that you've sort of developed if you're in these situations where you can turn to the family and explain, what exactly it is that's happening?
Yeah, there's no set script, but, you've got to think about it from the family side of things. And one, they're distraught from their patient or their family member or friend collapsing in front of them. And then secondly, they see you performing CPR, which is fantastic, and they really appreciate that. But then if the patient actually starts to wake up while you're doing the compressions, then it's very distressing to them. You have to take that opportunity, if you do have the resources there, to be able to explain. And I must confess that you're dependent on resources. If you've only got the two of you, then your attention should be to doing a resuscitation. You can provide brief information to the family at that stage. But if you have more of you, and maybe there's some of you or one of you standing around that actually hasn't got an active role, then your next role should be to go and speak to the family and obviously provide some support and education as to what's actually going on. It is very distressing, though, to see it as a family member from the other side. It'd be extremely hard. And you think about call takers. So somebody collapses from a cardiac arrest, we have a quick response, we get bystanders performing CPR, and they get CPR-induced consciousness. And what you find is dispatches, the call for a cardiac arrest will often go from a priority 0 back to a priority 1. So it'll be patients unconscious, agonal breathing, no pulse, and then they'll do some CPR. Patient's woken up and he's breathing, and then they'll stop the CPR. Patient back unconscious. And so the coding for those jobs can go back up and back down. So I think if ever you find yourself in a position that you're being dispatched to a job like that and the coding keeps on changing, it should just stay as a priority 0, and all the resources should be sent to go and assess. And then once you get there and determine that A, the person is awake and they're okay, or B, is unconscious in cardiac arrest and they're responding to good CPR.
That's really interesting. And talking about resources as well, if you are in, for example, a rural or remote area, that little bit further out from hospital, would you do helicopter or road for these types of cases if you're worried about the patient rearresting?
Yeah, I think so. Ultimately, that thing boils down to your location and where you're going to with the patient. More often than not, you probably won't experience it in a rural location because the time for the ambulance to get to the patient obviously is quite lengthened. So the chances of them having good perfusion by the time that you actually still get to them is going to be reduced. So, but if you do happen to find yourself in that situation where you are in a rural location, it doesn't matter whether you go by helicopter or by road, but the patient needs to be taken to an appropriate facility. And that's obviously one that can perform angiography and angioplasty and have a look and possibly perform bypass surgery if required.
Absolutely. That makes a lot of sense. And now I guess talking about, even though CPRIC is a rare thing that clinicians will go to, going to your general arrest, how does some of these, I guess, principles of managing this rare case apply to just a normal cardiac arrest?
I think the big difference is really if you don't have a patient that has any response during the cardiac arrest at all, you probably won't need to provide any sedation. It will be your routine management of a cardiac arrest, and that is, good quality CPR. And that's the mainstay of any good cardiac arrest management that you'll go to is, minimise your hands off chest time, ensuring that you provide the good depth with your compressions, allow appropriate recoil, and coordinate it with your ventilations. And don't over-ventilate the patients, but minimise your hands off chest when you need to do your defibrillation, and obviously administer IV adrenaline as required. If you do have a patient with CPRIC, the only difference really to those things is now you've got a patient that's going to be agitated as you perform the cardiac compressions on them, and you need to provide some sedation for them. So it is really only one additional thing that you've got to do, and that is obviously obtain IV access and administer sedation in the form of fentanyl or ketamine or whatever your service actually does. Does Queensland have a guideline for it now or not?
I believe Queensland does, and I think New South Wales, we're putting ours out with the new protocols coming out sometime this year. Yep. So I'm not 100% certain. I haven't actually read over them specifically, but I'm pretty sure they're now circulating around.
Sure.
Yeah, I think I only saw a couple of paragraphs in like the extra special circumstances of cardiac or CPR. So
yeah.
Do you think that this is something that should be sort of focused on in unis? Like, I know we've said a couple of times now it's 1 in 100 chance. Is this something that should be done as part of the cardiac arrest scenarios for students, or, ones who are wanting to get in that extra practice? Should they be looking at doing some scenarios about it so they've got that cognitive preparation before they walk into a potential scene?
Yeah, so I think if you are working in a service that has it as part of their guideline, then you should be familiar with it. If it's not in the guideline, it's probably nice to know about, but there's no point learning a guideline about it if it's not used within that service. Certainly within Victoria, I know some of the universities here in Melbourne, they do talk about it during their education. But at the end of the day, you know what it's like. 3 years of university, there is a shit ton of information that they want to cram into you, and this is a small component of that. So you've got to weigh up what's the really important things that people need to know about, as opposed to trying to give them everything and then not remembering everything. So I think there's more things that they could focus on, more so than worrying about the 1 in 100 potential case that they may come across.
Absolutely. That makes a lot of sense. And as a student, would, I guess, the take-home point from this be that for those that don't have it in their guidelines or anything, making sure that you can go, okay, I now understand what it is. These patients will need sedation. Is it best just to know that, okay, I need to call the consult line and in these situations?
Yeah, that's probably it. And so with the education at universities and so forth, nowadays they should teach you cardiac arrest management and then give you a 5-minute video that goes, there may be an occasion where you are exposed to a patient that has, return of consciousness while you're doing CPR. If you find yourself in that situation and you don't have a guideline to manage the patient, your options are consulting with the clinician, or if you have no communication, be aware of the guidelines that are actually out there. And I won't tell you to operate outside your own guidelines, but that's what I'm sort of telling you to do.
Just read between the lines there a little bit.
Yeah.
So there seems to be a lot more sort of conversations about it nowadays. Do you think that that's more to do with the fact that there's just more information? It's something that's being an actual topic that's being discussed? Or do you sort of mentioned Good Sam before. Do you think it's also to do with the early access to good CPR in some of our metro locations?
Yeah, so when we first started doing the research, we did a literature review. There were 9 articles on CPR-induced consciousness throughout the world. So 9 articles in general, and a couple of those were case studies, and the other ones were research articles that people had done. So It wasn't widely known about at all. Since then, Alex and I have done 3 research papers, and I've flogged this as senseless as I can, certainly within Australia, and I've been over to Scotland and America and tried to flog it over there. If you go and Google CPR-induced consciousness now, there are probably 50 to 100 articles that people have actually got onto and started talking about their experiences and the case studies that they've actually had. So the awareness of it has increased dramatically, and people have realised it's probably a good little research paper to write or a case study to write and put it out there for people to read about. So and I think people are generally interested about it because it is a rare confronting situation to be in.
And then, so could you run us through, so up in Queensland, we don't actually utilise Good Sam. Can you run us through sort of what that app is and what it sort of does and what it offers to the community?
Yeah, good. So Good Sam is a fantastic app. It's, I don't know where else it runs. It certainly runs within Victoria. The idea is that you register yourself with the app. So it's often nurses, paramedics, doctors, firemen, appropriately trained first aid officers. You register yourself with the app, and then if a cardiac arrest goes off you, I think it works in like a 2 or 5K radius from where you are, and your phone will make a funny noise, and it would just be like a siren and start going off and making noise. And then it will say, can you respond to a medical event that is near you? And you reply yes or no. And if you click yes, then it will give you the details. And when it gives you the details, it will say there is an AED that is located at blah, blah. So maybe 5 meters or 10 meters up the road from where the cardiac arrest has gone off. Your aim then would be to go to that closest location, pick up the AED and take it to the cardiac arrest. Because we know that early application of the AED will improve survival from cardiac arrest. So the idea is that, if I opened up my app now, you can see that there's a large amount of people who have put themselves on the app. And so when I open it up, I can see 1, 2, 3, 4, 5, 6, 7 people around me within a 2K radius who are prepared and ready to respond to a cardiac arrest if it goes off in the neighbourhood. And as you move around, it will move with you and it will show you who's around in the area, and it will also show you where those automated external defibrillators are.
Wow, it's an amazing sort of introduction into the helping with that early access. It's that information of knowing what's around you. So I guess if we sort of switch to just general cardiac arrest, so moving away from the world of CPRIC a little bit, a lot of the students who will be listening have either never encountered a cardiac arrest before, or, some of them, I have a few friends who went through their entire uni careers without ever experiencing one. Yourself walking in as the MICA paramedic, you're walking in typically to be the team leader at these sort of situations, I'm assuming. How do you sort of see the scene run? What would you give to the students as good bits of advice about how to fit into these scenes, which can be at sometimes quite high stress?
So I think as a student going into a cardiac arrest, the best thing you can do is say, what do you want me to help? So I think the easiest thing for anybody to assign to you is either 1, scribing, so taking down the times and administrations of any medications, or 2, the other simple one is to get you onto the chest and actually do compressions. Because I think there's a lot of apprehension as a student about the first time you put your hands on somebody's real chest and start pushing up and down. It's very easy to do it on all the mannequins you have at school. The chest caves in or it rips out, as they're all seen 1,001 resuscitations on them. But in real life, it's a different story. There's a lot of emotions that go on around. Family members and friends and all that sort of stuff add to the degree of anxiety you will have with going to one of those cases. So stick your hand up and say, how can I help? And be prepared to do anything that's asked of you during that cardiac arrest management. If you don't feel comfortable with something, then feel free to say, no, I don't feel comfortable with it. I'd prefer to just stand back. And that is okay as well. Your first time that you experience a cardiac arrest, it can be quite daunting, and don't be surprised if you feel that way. Don't be surprised that if after the cardiac arrest you find yourself in tears because of the emotions that's gone on. That's a normal emotion and a normal experience that you may get from doing these kind of cases. As you get exposed to more and more, you will be able to deal with them better and better. So don't be overwhelmed if you find it too difficult the first time you come across it.
Absolutely. That makes a lot of sense. And as a student who went to a cardiac arrest within the first week of my first ever placement, I noticed in that case that leadership and good quality, efficient communication was paramount in that case. And that's what I took away, I guess, the most out of that. How important is that?
Yeah, so I think within AV at the moment, they focus on the high performance CPR, and I think that's the same pretty much throughout most of the states in Australia. And I think that came from Seattle. They had really good cardiac arrest results. And so they talk about a what do they call it? It's not a cockpit, but a crew pit approach. You know, like when a car comes in from a car race and it pulls up to stop and everybody goes in together and someone undoes the bolts and someone pulls the tyre off, someone jacks it up, someone fills it with fuel. That's the idea of it with a cardiac arrest, is that we work as a team and we all have designated roles that we have to do. As I mentioned before, minimising hands off chest time is probably the most important thing. And if you do have the numbers, you need one person that actually stands back with a clipboard and a checklist and goes through and says, righto, we've got somebody who's managing the airway. Have you got a gastric tube in? Are you ventilating at an appropriate rate? Have we got somebody lined up to do the compressions next afterwards? It's getting close to the time that we need to check for pulse again and check the patient's rhythm to determine if we need to do defibrillation. So having a designated person who's running the show, so to speak, is really, like the conductor, is really important if you have the numbers. But if you don't, it's clear communication with your partner. If it's just the two of you there, be realistic with each other and say, you know, are you okay to keep on going with the compressions, or are you ready to swap over? The idea is that we do swap every 2 minutes, because it's been proven that, you know, lengthy times of doing cardiac compressions, regardless of how fit you are, your performance with the actual cardiac compressions will deteriorate over time. The use of mechanical CPR devices is a fantastic tool. I personally love them. The research sort of indicates that it doesn't improve cardiac arrest survivals at all, but what it does do is prevents fatigue of paramedics, prevents occupational health and safety issues of paramedics performing CPR for long periods of time. But it also provides that opportunity for, let's say there's only 2 clinicians at a job, you put the CPR device on, 2 clinicians can then sit back and go, where are we? What are we doing? As opposed to focusing on doing the compressions and tiring yourself out. So I'm a big believer in mechanical CPR devices, but not everywhere has them and is able to use them. So, but communication and clear directions in a cardiac arrest is of the utmost importance.
I think I might just add one other thing that I found, especially for students, is knowing the equipment that you have at the scene. So I've now done 2 cardiac arrests, one over in London and one that we did as a cross-border job with Queensland. You know, the partner that I worked for the cross-border job, he's got, you know, plenty of experience. He's done, you know, a ton of cardiac arrests, but we turned up and we were backing up a Queensland crew and we don't know Queensland kits. We don't know what they stock, what they carry. So it was really interesting to talk with him afterwards, because he felt like he was back at, you know, that first day on road, not being sure about what you had. And over in London, you know, when I was over there, each crew every paramedic had their own specialised kit. So the cardiac arrest, we had 3 paramedics and all 3 had their kits stocked in a different way. And so we ended up just doing a kit dump and throwing everything out of the kit bags so that we could find anything. So I think a really important take home that I took from that was being able to know what your equipment was and where to find it, so you're not digging through those bags. And I think as a student, that's something that you can be doing every day during truck check.
And that is, you know, when I go and teach at universities, one of the big things that I say is know your equipment. And, you know, one of my things that I used to enjoy doing was saying to the crew, okay, let's put this oxygen back together. And I would take it absolutely to shreds, take every bit of it, anything that came apart, I'd take it apart, dump it in a bag and say, put it back together. And as a paramedic, that is your equipment. You should know how to put that back together. It's like the old army days when you see guys disassemble their guns and put them back together really quickly. It should be the same with your medical equipment. You should know how it all works and how to put it back together. That's your environment. That's your working environment. You should know how it all works.
Absolutely. And that's what one of our previous episodes mentioned. So Joe Stevens said that, you know, if you're in the middle of nowhere and you have to apply, say, a Slishman, and you don't know how to do it, and you said, oh, I didn't go to that shoot, so I don't know how to put it on, that's not gonna go very well at all. So no. It's really important.
I think, you know, the other thing there, which is so common through university, and it's not just paramedicine, it's everything. You learn everything so crammed. You study for an exam, you sit the exam, you tick it off, and you go, beauty, that's done. I'll move on to the next thing, and you forget about what you've just done before. That's not something we can do in our profession. It is, you learn stuff and you have education about things, but the expectation is that you remember and retain that information and walk away and can apply it 6 months down the track. And it's really important that you go over your notes again and refresh yourself very regularly. When I go on annual leave, I'm away for 4 weeks of time. The day before I go back to work, I go through my guidelines again so that I review over things, because I don't have the working knowledge of my guidelines like I used to, but the guideline books are getting bigger and bigger and bigger nowadays. But you need to refresh yourself to make sure you are up to date and at least got an understanding and awareness of what you're actually doing.
That makes a lot of sense. That's actually really cool to hear that, paramedics who've been in the job for plus 20 years still do that. So that's reassuring. Going back to that cardiac arrest, whether that be in CPR-induced consciousness or just in a general arrest, it can be quite confronting for that patient's family. How do you, break that bad information or that bad news to that family?
Yeah, there's never an easy answer to that question, and some people take it much better than others, and that can obviously depend on family backgrounds, their nationalities, and many factors involved, whether it's a sudden death, an unexpected death, or whether it's somebody that's got a terminal illness that's actually expected to die. And having said that, regardless of what case it is, people still react differently each time. So, sudden, unexpected deaths, there's no easy way to break that to any family. The only thing that I recommend that you can do is say, I'm sorry, this is a horrible thing that's happened. I wish there was more that I could do, and just allow them the opportunity to grieve. And, if they want to cuddle, give them a cuddle. If they want a hand on their back, give them a hand off the back. And if they want space and want to be left alone, then give them that space and leave them alone. There's no easy way to break it to families. So what we tend to do during a cardiac arrest is usually around the 15-minute mark of working on a patient, I will go up, or someone will go up and have a chat to the family and say, listen, Mr. Jones, his heart has stopped beating. We're giving him medicine, which will hopefully try and improve his heart and get it working for us again. We're pushing up and down on it, trying to push the blood around his body. But at the moment, there's no activity going on in his heart. He's not breathing at all by himself at the moment. And we're doing everything that can be done for him in the hospital situation as well. But unfortunately, he's not responding very well at the moment. What our plan is at this stage is that we're going to continue working and trying to improve his heart again and get it going, working for him again. There's no guarantees though. At the moment, your husband is very, very sick, and it's unlikely that he's going to survive this event. And I hate to be the bearer of this news to you, but he's critically unwell at the moment, and I'm not sure whether he's going to survive. So you're sort of dropping the idea that, the outcome is not going to be very good. You also have to drop the idea that, the outcome may not be very good, but even if you do get a positive response, his long-term outcome from that may not be very good as well, because you don't want to give people false hope. When you tell them you've got a return of spontaneous circulation, they get elated and excited, which is good news, but you need to reassure that they are aware that he's definitely not out of the woods yet. He's got a heartbeat, it's going again at the moment, but he's still extremely unstable at the moment. He could lose this heartbeat at any moment. Our aim at this stage is to stabilise him as much as possible, transport him to hospital, but the next 48 hours to a week are the most critical time for him to ensure that we get the answers and we know where he's going to go and how he is actually going to survive.
I think for the students who are at those scenes, what's sort of your belief, I guess, on the learning opportunities available for those moments? So is that, obviously no one wants to have the student breaking that bad news. That's not the most valued position for them to be in at that scene. But do you think that there's that position available for them to maybe come and accompany a senior clinician to hear it so that they can experience and they can hear what the sort of conversation is? Or do you think that that's something that shouldn't be occurring?
Look, at the end of the day, I think a cardiac arrest in somebody's home, regardless of whether the student actually walks up beside you or whether he hears it from the room, hopefully they get exposed to it in some way. I personally wouldn't mind if the student came up and was there, because it gives them an opportunity to say things. And, the paramedic being there to support them during that period of time is obviously very good as well. It's very emotional, and like I said before, I wouldn't be surprised if a student with no experience with that type of stuff got emotionally upset during the delivery of the information, and that is perfectly okay as well. You're allowed to express your emotions during these cases. Alternatively, if you stay back and just have an ear out to what's occurring around the corner is also a good option for the student as well. But remembering as well that there are, not everybody's straight out of school as a student paramedic. A lot of them have probably got life experience beforehand. And we have a lot of people coming to us nowadays from teaching backgrounds or psychology or physiotherapy and all that sort of stuff. So a lot of them do have previous experience, and some of them are probably more experienced than me with dealing with that sort of stuff. Maybe they've done psychology and they know how to talk to grieving families and friends and so forth. So, you've obviously got to gauge what sort of experience the student has and give them an opportunity to make a choice as to whether they want to come with you or not.
That's really good. Well, like in my first cardiac arrest, on that first placement, the thing that made it I guess you could say a good learning experience was that my mentor in the truck before getting to the case said, "This is what's going to happen. I'll get you to stand back for the first 2 minutes and then let you take it all in. And then once those 2 minutes are up, if you're comfortable, I'll get you on the chest." And then he outlined what would happen during that cardiac arrest. And then they were great after and debriefed and asked any questions. But just having that knowledge of when I'm going there, I have a role already, and that is to stand back for the first couple of minutes, get comfortable with what's happening, and then get involved if comfortable to do so. So I think just knowing that from a student's perspective, so if you are on road talking to your mentors, going to that case and having that conversation can make that learning experience a lot better, I think.
Yeah, definitely. It softens the impact for you. If you've got a designated role before you walk into it, then you know what you have to do. Having said that, you never really know what you're walking into. Sometimes, cardiac arrest, there may be distressed relatives screaming and yelling at you, or there may have been a murder that's actually caused the cardiac arrest. So there may be blood all over the scene and all those sorts of things. Those sort of things can throw you off guard a little bit. But once again, your systematic approach to management of a patient shouldn't vary. If you have that same systematic approach each time, you'll find every job that you do to be fairly structured and straightforward.
Absolutely. That's really good. And that's something that's a recurring theme is the systematic approach.
Definitely saves you when you're at those jobs, and gives you something to fall back on no matter what's happening around you. You can always sort of ground yourself, have that focus point and that pause point for a breath, and then you can keep going once you've brought yourself back in.
Yes, definitely. Yep.
Awesome. Well, is there anything else you'd like to ask, Britt?
No, I think that's about it. I think it's been really cool to go back over the topic, because I will put my hand up. I haven't really looked into CPR since I heard Matt's presentation a few years back. So it was really good to sort of be able to go back over those key points and, sort of hear it from a different perspective, because obviously the first time I listened to it, I was sitting in the audience as a student, slightly hyperventilating about the fact I had to speak afterwards. But, now that I've now been able to go out on road and do these jobs and these arrests and see them from that different point of view of being there with the state service uniform on, it's really interesting to sort of hear that different perspective about how to change your behaviours and how to, control that entire scene, not just the medical aspect of it.
Yeah, I think, as a student, the most important thing to remember is that you're going to be overwhelmed when you first do these jobs. Do not expect that you're going to walk in and your shit is going to be under control as soon as you walk in there. You are going to be lost, confused, forget to do a few things, make a few mistakes. That is normal. We've all done it. I've done it. Every other person you've had on the show, Hodgie and Ben Meadley, they will have all made mistakes during their first cardiac arrest that they went to. That's the norm. Expect it to happen. Beat yourself up about it. That's fine, but get over it, because we all do it. And as you get exposed to more and more and more of them, you'll find that things start to click and you'll become more comfortable with actually doing them. You'll be more comfortable to speaking to others in the team while you're actually doing them. And then you'll start to become more experienced and comfortable speaking to family members as well. Don't expect to be able to walk in and do the whole lot in one go. It's never going to happen. Expect that more exposure and more time, you'll find that you get better and better at it.
That's awesome. Well, thank you so much for taking the time out of your day to chat to us. Hopefully you can go to the beach now. But definitely not the last time we're going to chat to you. I feel like be able to talk about your experiences all day. So
very good. Thank you very much for the opportunity to speak, guys. Have a great day.
Thanks for listening to this episode of the Student Paramedic Podcast. You can connect with us on Instagram, Facebook, Twitter, or you can email us at thestudentparamedicpodcast@gmail.com.